Hello everybody, welcome back here at the Vitrolife Group Academy at the studio here in Denver. The session we're going to do now is about optimizing patient treatment. And we have two very esteemed gentlemen here with us today. We have Professor Carlos Simon, who is the co-president and founder of the Carlos Simon Foundation in Women's Health, Research in Women's Health, and also Professor David Gardner, who is the scientific director of Melbourne IVF and professor of the University of Melbourne. Welcome, gentlemen, and
thank you.
Let's jump straight into it. David, I've got a first question for you.
Okay.
Over the last 45 years, we've seen a lot of development and changes in the field.
Yeah.
And we've also seen that there's certain treatment types where specific patient groups really benefit from.
Right.
What is your opinion going forward? Are there going to be more specific treatments for even smaller groups of patients that can benefit from it?
Right, and from a laboratory perspective? Okay, so I think we're about to see a lot of innovation come into the laboratory. There's a lot of talk about robots coming in and doing the jobs of embryologists, and that's all well and good. But I see innovation coming in the form of what we can put in the hands of the embryologist to be more effective and efficient. And what I mean by that is their job becomes streamlined, but it also means it's more effective for the patient. And a lot of these things are really trying to change fundamentals of what we've been doing to make it better, which in turn will help specific groups of patients. And I think that the specific groups of patients we all think about are the elder patients, right? I mean, they're the problem patients. And I think when you look at what we do in terms of, say, sperm preparation, ICSI, that hasn't changed really since we started. So with advances in microfluidics, but I'm talking next level advances where we're developing biomimetics. So these are chips where not only can you identify sperm with lower DFIs, but actually do diagnostics on the chip. Yeah. With regards to ICSI. That hasn't changed since '92, but now we've got the access to things like piezo, which may be more beneficial to patients with poorer quality eggs, advanced maternal age. We haven't changed the holding pipette at all. With developments in microfabrication, we can develop little like 3D egg cups to hold the egg to minimize stress. That could be very good for the elder groups of patients. So I see lots of things. But I think one of the really cool things that will be coming along is things like AI for sperm selection, but in testis biopsies. So this is said, you said a specific group of patients, so this is really a good one. Yeah. So this is for all the guys out there. So right now, when you're having a biopsy, the urologist is taking samples and hoping we're going to find some sperm. But if we can use AI, and we've been developing that, to actually identify the sperm and use that technology in theatre, you can stop the biopsy there and then and do minimal damage to the testis. Yeah. So personally, I think that's a huge advantage to any man to not have to go to the site. So
that's a very good practical example.
Yeah.
Carlos, a question for you. If we look at what we talk about here at Vitrolife Group, it's about having a healthy baby for our patients. Now, if we look at genetic disorders and the rate of hospitalization and infant mortality, we see that happen. How can we, with genetic testing, help to overcome that point where we don't see these early hospital admissions and mortalities?
Of course we can and we should. I mean, this is a main issue because in fact, infantile mortality has decreased a lot. But if you see in the last 20 years, the only niche that does not decrease are because of genetic diseases. Yeah. And recessive diseases are the ones that are in the majority of us. 85% of us, we have at least 3 recessive mutations. I have 4. And if you have the bad luck that your couple has the same like you, 1 in 4 of your children will be born with this cystic fibrosis, namely, whatever you have. So, I mean, we can prevent that. And this is a test that by doing this, you will know this information. And in fact, in countries like USA, this is mandatory. If a couple goes for an IVF procedure without this test, has not been informed, and they have children affected, the doctor could be liable for that. So, and this is going to happen worldwide. So, indeed, this is part of our job here and not even for IRT. Why not to have this information for everybody? And if you do not link, you don't have these shared recessive diseases, you can go for natural intercourse, but why do not to have this information for the most important process that you are going to do in your life, which is to have your own family?
Yeah, and I think it's very important to notice that also the technology is there, the tests are there. It's just about applying them into the treatment cycles. Yeah, David, another question for you. If we look again at the changes and the developments, we've seen at least the last few years a lot of technology changes. Now, you are one of the pioneers when it comes to culture media. Do you see we will get to a point where we can make a media that is even better than the optimal fertile person? Do we? Where do we go?
That's a very good question. I doubt we can actually get better than the very best fertile patient, but I do think we can get better at doing what we do in the lab. And again, if you think about what we do in the lab, we still put our embryos on a polystyrene dish and leave them alone for 5 days. Whereas in the optimal environment, the embryo is moving around, is exposed to different signals, is exposed to different environments, both nutritional, gaseous. So again, looking to the future, how are we going to do that? We've envisaged 30 years ago that this magic perfusion system would come to being. Now technologies have caught up, which is wonderful, and that we're on the verge of actually being able to fabricate micro devices where you could actually change the environment. But here's the punchline though. You said, can we mimic or better in vivo? But we're not in vivo, we're in vitro. So I think we need to get smarter than that and realize that we're working literally in glass and provide the embryos maybe extra things that we don't normally do. And I guess that's why we led the antioxidant story, because they're under stress when we work with them in vitro. So,
thank you. So, looking also at accessibility of IVF and how patients can access IVF. And this is a question for both of you. Looking at the developments that are coming, which parts of the IVF process can be done more remotely, can be less invasive, things that can be done from the patient's perspective?
Well, the trend now is to go for telemedicine, like we are going for everything here. So, now the visits are much shorter. To be able to do ultrasound at home, it is possible nowadays. To have those controls, every time we try to make things less invasive, more friendly for patients. Maybe I'm the oldest here, but there was a time that we obtained the oocytes by laparoscopy. Can you imagine what is it? So, well, you cannot imagine. So, yes, we are going to minimal to non-invasive. We are going to more friendly with telemedicine. And I think that things are getting simplified. But in addition to that, the most important thing is that we are more effective. We improve results, and we go not only for results, but also healthy babies. Because at the end, this is the most important result.
Yeah, exactly what he said. But also, you can do endocrine monitoring at home too, and those kind of things. And I think from a male perspective, now you can turn your smartphone, put a 3D printed lens on, and do an initial diagnosis at home, and then send that in to the clinic. And that's a lot less stressful for the guys. Like America in Australia, is that we have remote areas, and it's a big stress for people to have to come all the way in just to have a diagnostic test that they could actually have done at home. I think a commonality of what we both just said is reducing stress. And I think when we talk about what we do for the patients in treatment, I think quite holistically, and I'm sure a lot of people would agree, that as well as the interventions and the doctor's role, we should be doing more to minimize their psychological stress too. And there are other things that we could do along the way to help promote them have a better lifestyle, even promote better quality gametes through supplements. Maybe contentious, but I'm a big antioxidant fan, obviously. But there are lots of things that we can do remotely to augment their journey. And I think that's the big part of it, is to reduce the stress, because we know stress in itself has a profound impact on the quality and even the epigenetics, certainly of the sperm. So,
if you allow me, even the traveling is going to be reduced. The traveling for those things that cannot be avoided, like the oocyte pickup. There is a huge effort to be able that every woman, even if in the countryside, will have this care in order to have the oocytes there and get it to a center. So things are getting worked out to have more centralized facilities that things can be sent and the patient doesn't have to move as we are doing now. So yeah, more friendly.
It's interesting what both of you mentioned, the fact that the patient experience is also a very important point, reducing stress, physical, psychological, and we have the means to do that. So now, going a little bit further, AI again is a talk. There's a lot of AI algorithms going on. Do you think we can get to a point where we can use genetic testing to predict the type of treatment, the type of culture media, the type of stimulation that a patient should have in order to get the best possible outcome?
For sure. I mean, look around you. No faces, there is no faces that are the same. We are not the same. We are all completely, nobody is responding the same way to any treatment. And we know somebody that have lactose deficiencies so of course we are completely different. That's the reason why human beings, we are as we are. There are no faces alike here. And the same for the treatments. And we need to know what is the biological context of our patients when we give any type of treatments. And this is that this treatment is more effective day 5, day 6. Come on, be serious. This is not about the days. This is not about even the dosage. This is about everything in the context of the genetic background of the patient.
I couldn't agree more with everything you said. Pharmacogenomics is going to come. It's happening in many aspects of medicine. And like other things, eventually we get around to reproductive medicine. But it's going to have I think it will have a profound effect. Your question was also about embryos. Yes. Yeah, I don't see why not. I think again, looking to the future, I'd like to see a system whereby we're able to monitor each embryo. And there are many ways we could be doing this through novel microscopies such as hyperspectral or media analysis, and then use AI to feed back and create the environment that particular embryo needs. It's not beyond it's not science fiction anymore. It's fast becoming something that we can consider.
Great. Maybe getting towards the end of our discussion today. Carlos, you've been doing a lot of work around the endometrium. David, you've been doing a lot of work around the embryo, and we're learning more and more about the endometrium, and we still need to get to that point where we put the best embryo into the best possible embryo at the best possible time. Where are we with this journey of getting to that point of the best embryo in the best endometrium at the best time?
We are getting this discussion for 30 years now. And in fact, this is exactly what we used to do in ASRM. This was, but the problem is this guy did such a good job with the embryos that it looks like the embryo is everything, and it's everything. But yeah, the mother also exists. Okay, no, truly, you need the embryo to start. You need the embryo is the start of the whole thing. But we know, I'm biased, but we know more and more that the soil is key, and. Nowadays we are learning, for instance, about decidualization resistance. The fact that if the endometrium is not good enough, you are going to have a preeclampsia or you are going to have an endometriosis. So what I mean is that our body is all together. So we have to consider the whole process together. But the embryo is fancy, is more beautiful, and it divided. So it is very apart.
So it's true, it was about 30 years ago at this meeting that we had this dueling banjos. And I used this phrase, and I still use it, and it was the exquisite dialogue that takes place between the blastocyst and the endometrium. So to say whether it's the seed, the blastocyst, or the soil is important. But the actual magic happens is when the seed and the soil are talking. And I think what's really exciting is we're starting to understand more about what those communication pathways are. That, I think, is really going to change into the future without disclosing too much about what we're doing. But I think it's a really interesting thing, and I think it comes back to that dialogue. Understanding receptivity, understanding what makes the best embryo is great, but understanding how to make that initial communication is the key.
Allow me, going back to personalization, there are faster and slower embryos. There are faster and slow in endometrium. So again, personalization goes to the periconceptional space. As David mentioned, this dialogue and to know which partner has this faster or lower protocol is key.
And again, I just want to reiterate the fact that the technology is there. A lot of these tests are available. It's more about education, training, getting people to understand the importance of utilizing these specific protocols or techniques in order to get the best possible outcome. Listen, David, Carlos, thank you very much. I invite all of you to hang around. We've got another session with Carlos just after this. But thank you very much for your input here. Thanks.